Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Right now, up to a quarter of the people walking around outside have basically a loaded spring in their abdomen.
Yeah, a total ticking time bomb.
Exactly. Their right colon is completely unattached, just floating freely and waiting for the exact wrong moment to twist into a fatal closed-loop obstruction.
Which is terrifying when you think about it.
It really is. So, welcome to today's deep dive. This one is built specifically for those of you who are doctors, surgeons, or, clinical staff walking the wards.
We are unpacking the clinical literature on Caecal Volvulus today.
Right. We've pulled together a massive stack of peer-reviewed sources. We're talking data from the NCBI, radiological insights from the AJR, and the RSNA.
It's a lot of ground to cover.
Yeah, but our mission here is to dissect the mechanics of this high-stakes, do not miss surgical emergency. We want you to recognize it before it cascades into a complete catastrophe.
Absolutely crucial.
But before we jump in, a quick reminder that this content is for reference only, and you should always follow local guidelines in your clinical practice.
For sure, because the margins for error with this pathology they're incredibly thin.
Right.
We're looking at a condition where the entire sequence of events, from symptom onset to irreversible tissue necrosis, it can unfold in just hours.
Wow, hours.
Yeah, so it really demands an understanding of not just what's happening anatomically, but the cascading physiological consequences that follow.
Okay, let's unpack this. Let's start with that anatomical trap.
Okay.
The prerequisite for this whole disaster is incomplete peritoneal fixation, right?
Yeah, exactly.
We're talking about a developmental variant where the right colon fails to fuse to the retroperitoneum during embryological midgut rotation.
Right, it just never anchors down.
So instead of being firmly anchored, the caecum and ascending colon are essentially floating on this hypermobile mesenteric tether.
And what's fascinating here is that mobility creates the environment, but it's the specific geometrical twist that turns a harmless variant into a dangerous volvulus.
Right.
We typically see two distinct anatomical patterns. The classic one is the axial volvulus.
The true twist.
Right. The caecum, terminal ileum, and proximal ascending colon all rotate around their own mesenteric axis, and that physical twisting actually displaces the caecum out of the right lower quadrant.
It thrusts it upward, right?
Yeah, usually right into the left upper or mid-abdomen.
I picture the axial volvulus as taking a soaking wet towel and just physically wringing it out from the center.
That is a perfect analogy.
Because you're torquing the tissue and the blood vessels simultaneously.
Oh.
But the literature also describes the caecal bascule, which seems mechanically different.
It is. The bascule behaves more like a folding mechanism.
Like folding a heavy piece of cardboard.
Yeah, exactly. The caecum flips anteriorly and superiorly over the ascending colon. You aren't torquing the mesentery in a tight spiral like you are with the axial type.
Which changes the clinical timeline, doesn't it?
It does. Because of that lack of severe mesenteric twisting, a bascule can sometimes present with a slightly slower progression to vascular compromise. It still produces an obstructed, massively distended caecum, but the immediate ischemic threat isn't always as rapid as that tight knot of an axial volvulus.
Interesting. But both types require some kind of trigger to set them off,
yeah.
Right?
Usually, yes. We see adhesions from prior abdominal surgeries acting as a fixed fulcrum. We also see pregnancy displacing the bowel, chronic constipation, and colonic dysmotility.
Okay, wait. I have to push back on the epidemiology here.
Go for it.
The sources say that 10 to 25% of the population has this loose peritoneal fixation.
Roughly, yeah.
So if up to a quarter of the people coming into the ER have a floating right colon, why aren't your ERs completely overflowing with this on a daily basis?
Just fair question.
I mean, why does a 40-year-old patient who has had this mobile colon their entire life suddenly twist on a random Tuesday?
It really comes down to the sheer biomechanical bad luck required to create a persistent closed-loop obstruction. Yeah, mostly. Because most people with mobile colons experience transient shifts. The bowel might twist slightly and then naturally detorse as peristalsis continues.
It just untwists itself.
Right. For a true volvulus to take hold, the bowel has to rotate just enough to create a one-way valve.
Ah, the one-way valve.
Yeah. Fluid and gas get pushed into the caecum from the small bowel, but the twist prevents anything from emptying out into the transverse colon.
So the trap springs shut.
Exactly.
And once that one-way valve forms, the physiological cascade must be brutal.
It accelerates exponentially. As the closed loop distends, Laplace's law dictates that the wall tension just skyrockets,
Right.
and that rising intramural pressure quickly exceeds capillary perfusion pressure.
So the blood flow gets choked off.
First, the thin-walled venous outflow compresses, so blood is pumping in through the arterial side, but it can't drain out.
Wow. So it just swells.
Massively.
Yeah.
The bowel wall becomes grossly edematous, weeping fluid into the lumen and third spacing into the peritoneum. Eventually, that severe congestion chokes off the arterial supply entirely.
Leading to thrombosis, ischemia, and gangrene.
Precisely.
That physical progression perfectly explains the clinical presentation then.
It maps directly to it.
A patient walks through the doors presenting with what looks like acute large bowel obstruction. They complain of colicky abdominal pain.
Usually starting periumbilical.
Right, as visceral pain from the stretching of the bowel.
Yeah.
But as the distension worsens, it becomes more generalized.
And they present with absolute constipation.
Yeah, and eventually late-stage nausea and vomiting.
And when you examine them, you'll definitely notice gross abdominal distension.
Right.
Percussion reveals marked tympany, frequently in the central or upper abdomen, because of where that displaced gas-filled cecum has migrated.
What about bowel sounds?
Early on, auscultation might reveal high-pitched tinkling bowel sounds as the gut desperately tries to force contents past the block.
But later.
Later, as ischemia sets in and the bowel paralyzes, the abdomen just goes dead silent.
Okay, but let's be real. To a doctor on a busy Tuesday night in the ER, this sounds like 100 other abdominal complaints.
Oh, absolutely.
I mean, how is a clinician supposed to know it's this specific emergency and not a severe case of gastroenteritis or a standard small bowel obstruction?
And that diagnostic ambiguity is exactly why mortality rates can be so high. It's a clinical chameleon.
Because early on, their vitals might be fine.
Perfectly stable sometimes. If you are waiting for the classic red flags, rigid peritonism, tachycardia, hypotension, or metabolic acidosis with a soaring lactate, you are already behind the 8 ball.
Because by the time the lactate rises, the liver is already overwhelmed by the necrotic tissue burden.
Exactly. Peritonism means transmural ischemia has progressed to the point where inflammation is irritating the parietal peritoneum.
It's too late.
Yeah, elevated lactate is a massive harbinger of established necrosis. If those signs are present, perforation is likely imminent.
If it hasn't happened already.
Right. Relying solely on clinical exams and basic labs leaves the clinician flying blind during that critical early window.
So if the clinical exam is a dead end early on, we have to look inside. This brings us to the radiology showdown.
Yes, imaging is everything here.
ER doctors frequently order plain abdominal radiographs as a first-line diagnostic tool, and the literature constantly mentions the classic coffee bean configuration.
The famous coffee bean sign.
Right, a markedly dilated gas-filled cecum displaced to the midline or left upper quadrant. But here's where it gets really interesting.
Oh, yeah.
Isn't the coffee bean sign also found in sigmoid volvulus?
It is.
If a clinician relies on a blurry plain film and misidentifies a Caecal Volvulus as a sigmoid volvulus, aren't they setting the stage for a catastrophic intervention?
It happens, and the results are often fatal. Plain films are notoriously dangerous in this context.
Because they're just 2D shadows.
Exactly. You're looking at a two-dimensional shadow of a complex, three-dimensional disaster. That shape is frequently obscured by fluid-filled loops, overlapping gas, or just patient habitus.
And the physiological trap of misdiagnosis.
The standard initial management for a sigmoid volvulus is endoscopic decompression.
Right, passing a tube.
A gastroenterologist or surgeon passes a scope or flatus tube to untwist the bowel. But if you attempt to pump air or contrast into a caecal volvulus via colonoscopy,
Oh, man.
you are introducing extreme pressure into a massively distended, closed-loop caecum whose walls are already stretched paper-thin and likely ischemic.
The risk of blowing it out must be massive.
The risk of iatrogenic perforation is huge. It's highly unreliable and dangerous.
So plain films are out, which means a contrast-enhanced CT of the abdomen and pelvis is the definitive tool.
CT is the absolute diagnostic modality of choice in adults. The sensitivity and specificity are unparalleled.
What exactly are we looking for on the CT?
You're specifically looking for a massively distended caecum, often expanding past 9 to 10 centimeters.
Yeah, and the distal colon.
Completely decompressed because that one-way valve prevents any gas or fluid from moving forward.
Right. But the most critical finding, the definitive sign, is the transition point.
The whirl sign.
Yes. The whirl sign. It's like looking at a hurricane from space.
I love that analogy.
It tells you exactly where the storm's central axis of destruction is. You see that spiral configuration of the mesenteric fat and the engorged vasa recta twisting around a central axis.
The hurricane analogy is incredibly accurate. The CT scanner effectively maps the eye of the storm.
That's amazing.
And adjacent to the whirl, you will frequently identify the bird's beak sign.
Which is what exactly?
It represents the progressive tapering of the opacified bowel loops, pointing directly toward the exact site of the torsion.
And the CT also gives us the crucial anatomical landmarks to differentiate this from a sigmoid volvulus or cancer, right?
It does. A sigmoid volvulus typically points its apex toward the right upper quadrant,
Okay.
whereas the caecal volvulus apex generally points toward the left upper abdomen.
Got it.
Furthermore, the CT instantly differentiates a volvulus from an obstructing left-sided colon cancer or a stricture.
Because a tumor wouldn't have the whirl.
Right. A malignant tumor will present with a single transition point featuring concentric mural narrowing, but you won't see that chaotic, swirling mesenteric root.
So the CT scanner provides an immediate map of not just the block, but the vascular compromise.
Yes. We look for mural thickening, a lack of intravenous contrast enhancement in the bowel wall, pneumatosis intestinalis, and portal venous gas.
And seeing portal venous gas or pneumatosis, that changes the surgical urgency from soon to immediate.
It confirms that mucosal integrity is gone and gas-forming organisms are dissecting into the bowel wall and the portal circulation.
Wow. Okay, so once that CT scan confirms a caecal volvulus, the action plan shifts entirely.
Non-operative management is completely off the table.
Because, as you mentioned, endoscopic decompression is actively dangerous here. So the patient is heading to the operating room.
Yes.
What are the specific preoperative resuscitation steps that need to happen while the OR is being prepped?
You have to optimize the patient aggressively while the surgical team scrubs in.
So massive IV fluids.
Yes. Prompt IV fluid resuscitation to counteract the third spacing of fluid into the obstructed gut.
What else?
It requires passing a nasogastric tube to decompress the stomach and prevent aspiration, and initiating broad-spectrum antibiotics to cover the inevitable translocation of gut flora.
Makes sense.
But most importantly, surgical consultation must happen the moment the diagnosis is suspected, long before hemodynamic deterioration sets in.
Time is tissue.
Exactly.
Okay, so the patient is in the OR, the midline laparotomy is performed, and the surgeon physically encounters the volvulus.
Right.
Let's discuss the intraoperative decision-making. If the bowel is gangrenous, perforated, or clearly non-viable, the literature is pretty clear.
A right hemicolectomy is mandatory. The necrotic tissue must be resected.
Right.
You have a massively dilated ischemic structure spilling toxins into the bloodstream. The surgical challenge here is substantial.
I can imagine. Handling a 12-centimeter, paper-thin, gangrenous caecum.
It requires extreme meticulousness. The slightest rough traction can cause the bowel to rupture, spilling highly infectious fecal contents directly into the peritoneal cavity.
Which drastically increases the risk of post-operative sepsis and mortality.
Dramatically.
So assuming the surgeon successfully mobilizes and resects the necrotic right colon, they face a divergence in the pathway based on patient stability.
Correct. If the patient is hemodynamically stable and the remaining bowel ends are well perfused, the surgeon will perform a primary anastomosis.
Rejoining the terminal ileum to the transverse colon.
Right. However, if the patient is hypotensive, on high-dose vasopressors, or in severe septic shock,
a primary anastomosis is contraindicated.
Absolutely.
Because anastomotic healing is entirely dependent on adequate tissue perfusion.
Right.
If the patient is shunting blood away from the gut to preserve their core organs, that connection is just going to break down and leak.
Exactly the issue. In an unstable patient, the safest, most damage control-oriented approach is an end ileostomy.
So bringing the bowel out to the skin.
You bring the viable small bowel out to the abdominal wall as a stoma, staple off or exteriorize the colonic stump, and close the abdomen quickly to get the patient into the ICU for physiological recovery.
Okay, I have a direct, challenging surgical question for you here.
Lay it on me.
So what does this all mean for the surgeon if they open the patient up and they untwist the caecum and the bowel is perfectly pink?
It's totally viable.
Yeah, totally viable and healthy. Why are the guidelines still telling them to cut out a chunk of the colon to do a hemicolectomy instead of just untwisting it and closing the abdomen? That feels so aggressive.
It does feel aggressive, but if we connect this to the bigger picture, the philosophy comes down to recurrence risk.
Okay.
Untwisting the bowel treats the acute obstruction, but it ignores the fundamental anatomical flaw.
The loose peritoneal fixation.
The hypermobile mesentery remains entirely intact. If you perform simple detorsion, the recurrence rates are unacceptably high.
You're leaving the loaded gun on the table.
Exactly. A right hemicolectomy definitively cures the disease by removing the anatomical anomaly entirely.
But surely there are patients where a major resection, even a viable bowel, carries an unacceptable physiological toll.
Oh, for sure.
Like, what if you have an 85-year-old patient with severe cardiac disease and COPD? A right hemicolectomy involves major surgical stress, bleeding risks, and anesthetic time.
Right. For those highly selected, poor operative risk patients with viable bowel, surgeons can opt for a detorsion followed by a cecopexy.
Fixing the cecum to the abdominal wall.
Exactly. Physically suturing the mobile cecum to the lateral parietal peritoneum or the abdominal wall to anchor it in place.
So why isn't cecopexy the standard for everyone then? It seems way less invasive than cutting out the colon.
Because it is mechanically inferior.
How so?
You are placing sutures into a thin-walled, previously distended and traumatized structure. When normal colonic motility and peristalsis return, the mechanical forces pulling against those fixation sutures are immense.
Ah, so they tear.
They can tear right through the tissue, leading to either a recurrent volvulus or an iatrogenic perforation down the line.
Which is why the data shows higher recurrence.
Yes. The data shows cecopexy carries a significantly higher recurrence rate compared to resection, so it is strictly reserved for patients who cannot survive a hemicolectomy.
What about the surgical approach for the caecal bascule? Since it's a fold rather than a tight twist, does the management change at all?
The principles remain identical.
Really?
Yeah. Whether it's an axial volvulus or a bascule, the underlying defect is the mobile right colon. The bascule requires resection or pexy based on the exact same viability and patient fitness criteria.
Okay, that makes sense. And this is all open surgery, right?
Generally, yes. It is important to note that while laparoscopic approaches have been utilized by highly skilled surgeons in stable, elective, or semi-elective settings,
It's not the standard for emergencies.
no, an open midline laparotomy remains the gold standard in emergencies. The surgeon requires maximum visibility to safely handle the distended bowel and assess the entire mesenteric route.
Got it. Now, the operative intervention neutralizes the immediate mechanical threat, but the cascade of physiological damage doesn't just end when the fascia is closed.
None at all.
The post-operative journey for these patients is incredibly precarious.
Meticulous critical care is paramount post-operatively. Standard large bowel surgical protocols apply, but these patients undergo massive fluid shifts.
Because of the edema.
Right. The edema in the bowel wall begins to mobilize, and reperfusion injury can trigger profound systemic inflammatory responses.
So you're managing major electrolyte derangements, monitoring for ongoing sepsis, and keeping a hypervigilant watch for anastomotic leaks if a primary connection was made.
Yes. Furthermore, the massive pelvic and abdominal venous congestion created by the volvulus puts these patients at an exceptionally high risk for deep vein thrombosis and pulmonary embolism.
Wow, okay. So DVT prophylaxis is huge.
Aggressive, early DVT prophylaxis is mandatory as soon as the surgical bleeding risk permits.
It all highlights how unforgiving this pathology is. From the vague initial presentation to the rapid ischemic cascade, every step requires clinical suspicion and decisive action.
And the most critical takeaway from the literature is that patient outcomes are fundamentally tied to diagnostic delay.
Right.
Once transmural ischemia, perforation, or peritonitis develops, the mortality rate skyrockets from the low single digits to upward of 30 or 40%.
It really is a high-stakes race against the clock.
It is.
The moment the CT scanner identifies that whirl sign, the starting pistol fires,
Yeah.
recognizing the signs early, understanding the absolute inadequacy of plain films, and moving immediately to definitive operative management before necrosis sets in. That is the literal difference between life and death.
It requires a high index of suspicion on the wards and in the emergency department.
You really have to look for it.
If a patient presents with bowel obstruction symptoms and the clinical picture is deteriorating faster than a standard obstruction should, Caecal Volvulus must be on the differential.
Unpacking the mechanics of this, from a developmental anomaly in embryology to a surgical crisis decades later, is just incredible.
It's a fascinating pathology.
And it leaves me with a final thought for you to mull over based on the anatomy we've discussed today.
Okay.
Since 10 to 25% of the population walks around with this mobile right colon, will future imaging advancements eventually allow us to predict which of these colons will actually twist?
Oh, wow. Like AI modeling.
Yeah. Could we one day see a world of preventative, elective caecopexies to disarm the trap before it ever springs?
The evolution of prophylactic surgery based on advanced anatomical modeling is an incredibly compelling frontier. It will be fascinating to monitor how the clinical guidelines adapt as predictive imaging becomes more sophisticated.
Absolutely. Well, if you like this content, please don't forget to share this deep dive with at least one of your colleagues or friends to help spread the word.
Every share helps.
It really does. Also, be sure to check out our YouTube and other social media pages, and definitely dive into our previous season and episodes for some very relevant clinical topics.
Thank you for joining us today to dissect the clinical literature. Stay vigilant out on the wards.
Thanks for listening, everyone. Remember to look beyond the vague symptoms and keep an eye out for those loaded springs. We'll catch you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.